What we need to demonstrate and model is that we are leaders. We are entrepreneurs. We're going to push the entirety of the spectrum of kidney disease. We're from pre-dialysis care, the transition to dialysis, home dialysis, uptake of new technologies, thinking about GN, thinking about onconephrology, et cetera, et cetera. How do we as a specialty become leaders and push the envelope on generating value for society? I think that is what we need to advertise for trainees. And I think trainees are itching for working hard.
Thank you for listening to this podcast by the American Society of Nephrology. I'm Todd Ibrahim, Executive Vice President of ASN. If you're a nephrologist, fellow, or kidney health professional looking to advance your career, stay informed, and build connections, I encourage you to become an ASN member. Membership, which is free to fellows and other trainees, offers exclusive access to groundbreaking research through our journals, discounts to live and virtual educational programs, including Kidney Week, and support of a global network of nearly 22,000 kidney professionals. To learn more or join ASN, visit www.asn-online.org.
Hello and welcome to the American Society of Nephrology podcast series, Convergence, a historical assessment of kidney diseases, nephrology, and health policy in the United States. My name is Andrew Cohen, Professor Emeritus of Medicine at the Warren Alpert Medical School of Brown University. Once again, thanks to the American Society of Nephrology, my co-creator Todd Ibrahim, ASN Executive Vice President, and a very special producer, Catherine Buckler. In 1972, Medicare coverage was extended for patients with ESRD. There were two competing visions for dialysis care. One, championed by Belding Scribner and his colleagues in Seattle, was based on home dialysis, both hemo and peritoneal, coupled with regional dialysis centers for small numbers of patients who were unable to dialyze at home. The other, an entrepreneurial model of widely dispersed hemodialysis units, was promoted largely by the newly organized corporate entity, National Medical Care, which later became Fresenius. 5 years later, Scribner took on Eugene Shupak, then president of NMC, and John Merrill in a debate before the subcommittee on health of the Ways and Means Committee. This body, which provided the initial 1972 legislation, was considering amending it to provide targets and incentives for increasing home dialysis use, which by then was on the wane. Congress ultimately did not pass this legislation, and the so-called East Coast model more or less describes our current delivery system of dialysis care. We are fortunate today to have three expert colleagues to discuss the merits and challenges of our current dialysis care delivery system. Suzanne Watnick currently serves as health policy scholar at the American Society of Nephrology. She is also a professor of medicine in the Division of Nephrology at the University of Washington. I might say she is therefore a direct descendant, nephrologic descendant of Dr. Scribner. She also serves several additional roles, including chair of the ASN Public and Advocacy Board and a member of the Board of Directors of the American Board of Internal Medicine. Manish Tanna has been in private practice with Nephrology Associates of Northern Illinois and Indiana for the last 25 years, until being named president in 2024. As president of NANI, he leads 150 nephrologists and 50 advanced practice clinicians over 3 states. So he holds several hospital and dialysis leadership positions, including the National JV Council Chair for Fresenius. Dr. Eugene Lin is an assistant professor and a nephrologist and health services researcher at the University of Southern California. His expertise is on federal regulation and kidney care, dialysis in public and private insurance markets, and dialysis payment. His work has been published in leading health policy and medical journals, including JAMA Health Affairs and JAMA Internal Medicine. Okay, let's talk a little bit about how we got here, and to extend a bit on the history, since you, Suzanne, are connected in many ways to the history of this story. Maybe you could bring us up to date a little bit about how we got from those early competing visions of dialysis care to where we are today.
Well, I'm not sure we have enough time, but to really get into the deep details. But I think it's worthwhile even rewinding back before 1972 when the legislation was passed. And just to remember that, chronic dialysis didn't exist until a Scribner shunt actually allowed for chronic maintenance treatments to occur. And at that time, it was felt that this was intended to be a form of rehabilitation for people to be able to get back to work, to be able to be productive members of society. And it was very patient-centric. The patient was the unit. If you really want to think from a business perspective of, how they designed care. Centers were created so that people could come in, dialyze, and then leave, get on with their life. The initial facility was actually in the basement of nursing dormitory in Seattle. And people would come in the center of Seattle, and people actually moved to the area so that they could continue to support their families. And so as things evolved to actually get the benefit passed in 72 and begun the following year, suddenly there was the opportunity for payment for this. And so if you think about the 70s as facilities were being built, and actually at the VA was one of the first places where networks were built, again, with the concept of it being veteran-centric, people would come many miles around to be able to, basically access this life-sustaining therapy. And as we moved into the late 70s and early 80s, people recognized that there was the opportunity to expand this further and to be able to get payment in an outpatient environment to essentially do cardiac bypass, which is really what this was, in an outpatient setting where you had dialysis machines sustaining life and you had life support being provided. There was the recognition that there was a financial benefit as well. And so we saw into the early 80s basically the continuation of facilities being incorporated and, basically popping up. And really the program, which was anticipated for a small number of people, ballooned to be really more than 100 times the size and more than 100 times the expense.
Just to fill in a little bit of that, I think the original thought, at least by Scribner and by the Gottschalk Committee, which preceded Scribner's work in the 1960s, was to use dialysis largely as a bridge to transplantation. Isn't that the sense that you get? Also, as you implied, no one anticipated without any kind of restrictions imposed by the 1972 legislation, no one anticipated either the numbers or the severity of comorbidities that dialysis patients were going to have in the years and decades that followed.
Very true. Again, although transplantation was available, at least in the Seattle area, it was recognized that there were many patients that wouldn't be able to access that either. Although it would potentially be a bridge, we also had the initial patients lived more than a decade, which is very unusual now because, again, many people with much higher levels of comorbidities were then brought into the program, which was never anticipated. It was never anticipated to be the size of the program, like you said, or to be dialyzing people that had the degree of comorbidities that they had. So very much the case.
I just want to jump in. The transplantation topic is, a whole other topic that probably warrants its own podcast. But NOTA, which is the current framework for how modern transplant is regulated, wasn't passed until the 1980s. And so Even with that type of framework, I mean, the way we think about transplant now is completely different from back then. I also do, I can't help but insert a health economist lens into this, but there are just interesting tidbits about how the history was on reimbursement back then. So in the 1970s, Medicare itself was nascent, and most of the reimbursement structures back then followed a cost-based reimbursement structure. And dialysis was no different. I don't think policymakers thought of dialysis as this unique entity relative to other parts of Medicare. But what happened with the cost-based reimbursement structure is that explicitly rewarded hospital-based facilities. And so what you saw was there wasn't a whole lot of growth in freestanding clinics. You saw large growth in hospital-based clinics. And that was one of the big things that contributed to a decline in home dialysis use, which prior to the 1970s was sort of like the majority of dialysis provision. And it was only in 1980 when there was a legislation that mandated the introduction of bundles. And, dialysis, again, not unique. This was also bundled payment systems were introduced in, the inpatient setting. What ended up happening is that you had a flip on what was rewarded from a reimbursement perspective. And that's when you start seeing like a growth in freestanding facilities. So there is this sort of interesting sort of thing where industry is following where the dollars are being put.
Right. And that's an important part of the theme of what we're discussing today. Since we're talking about corporatization, do any of you wish to venture a definition of corporatization, and what does that mean, and how does that apply to today's topic of dialysis care?
Well, I think corporatization emphasizes scale and standardization, and the need for us to make sure that all patients are treated with a certain level of quality that is expected among different clinics. I think that's, at least from a clinical perspective, what I take from the word corporatization.
Yeah, I don't think it's the intent of our discussion here to bash corporatization. We certainly know the advantages, as you point out, of economies of scale that corporatization presents. The fact that these large companies, we're talking largely about Fresenius and DaVita, have been able to provide accessibility to dialysis throughout the country. And many people would argue that this would not be able to take place without this being part of a corporate structure. But there are also issues that are raised by corporatization, and that's, I think we'll ultimately want to get into that. So,
yeah, I might introduce like a slightly, and I agree, I really like that definition, the idea of how do you scale, and maybe like quibbling around the details. I do think academic centers, for example, have behaved a lot more like this in the last decade, let's say, in terms of more acquisitions of private clinics, et cetera, and trying to increase their scale and market reach. And one could say that is corporatization of academia, like no doubt. I think that's a big criticism of the behavior of academic centers. I do think, though, there is this other piece of it that people sort of, I guess, maybe think about emotionally. And I don't know if this is like a really good technical definition, but at least when you think about publicly traded companies, those companies have a fiduciary responsibility to their shareholders. That's different from, say, the way a private practice group or even a large private practice group thinks about their profits and losses. And I think, of course, everybody who's, doing a vocation in the US is looking to make a profit because you have to put food on the table. But I think that's sort of the introduction of a third party that has a financial interest that's beyond, that sort of potentially competes with the patient's interest and, the provider's interest. I think that a lot of people think about with respect to at least the dialysis industry.
Yes, and I think we'll be getting into some of those in detail over the course of the next few minutes. So what does this mean to have this kind of high volume, high margin type of corporate entity mean for nephrology in particular? I think, also we're using nephrology in a way as a microcosm or a lens to look at the larger issues in modern American medicine, but specifically for nephrology, what does this mean?
I would add, Andrew, nephrology is one of those specialties where we have specific targets that we need to make sure that our patients achieve in order to obtain good quality care. And dialysis specifically has a very expensive and difficult process to provide because the margins have been tightening for the last several years. And so what we're seeing is that these outcomes that we've all set as targets for our patients, they can only be achieved by those units that are efficient at providing that type of care. And so I think that's why we're seeing this type of decrease in the number of companies that are able to provide dialysis in the country, because there's just such an advantage of scale when you talk about trying to provide this level of service to achieve these metrics.
Mhm.
And it's interesting you say that because, in having a number of discussions with people at the Centers for Medicare and Medicaid Services, CMS, over the last couple of years, they talk about the smaller dialysis organizations should be able to pivot, and they should be able to do and provide innovative therapies that are patient-centric. They may not have the fiduciary responsibilities that Dr. Lin was mentioning to shareholders. However, the profit margins are so narrow to disappearing that they have challenges. And I personally experienced that as chief medical officer of a smaller dialysis organization, despite having the patient right in front of us constantly to benefit, to really not have capital, for example, to bring in the latest innovations. When you have, for example, newer machines that may be truly more than double the price of prior dialysis hardware, it's a challenge. And so despite best efforts, you do what you can do, but you still have the competing larger dialysis organizations who do have the economies of scale, for example. And, fortunately, we've been in a situation where we've been able to start thinking a little bit more about the value that we bring to our patients. So with the Innovation Center that was started with the Affordable Care Act back in 2010, we saw, accountable care organizations being brought to the forefront. And actually, the nephrology environment was the place where subspecialties first had their toe in the water with a value-based care model to try to actually bring reward to those groups that brought quality to the forefront with the ESCO model. We did see some benefit for patients with decreased hospitalizations, but one of the things that we really wanted to see was making sure that patients had further options and were able to experience all options, for example, with home dialysis, but we didn't see that with the initial model. I hope we get to talk more about the kind of care that we're trying to bring in with Accountable Care 2.0 and 3.0 as we continue this conversation, but I just wanted to make sure to bring that aspect of care, because I think it's really shaping how we think about nephrology, not just as dialysis organizations think about it, but also as nephrology practices think about it. And I know Dr. Tanna has a lot of experience with that.
Yeah, thanks, Suzanne. That's very well said. As I speak to my non-nephrologist colleagues, what I'm struck by is the lack of knowledge that they may have about the cost of treatments within their specialty or subspecialty. Nephrologists, on the other hand, are very different. We are very well aware that 1% of the Medicare population is on dialysis, and yet 7% of the Medicare spend is for those patients. And that's been ingrained into our psyche now for the last over 10 years. And so that brought on our participation in things like the ESRD Seamless Care Organization, ESCO, as well as the 2.0 versions, the CKCC. And we've learned a lot of lessons with these types of programs, both in the voluntary and mandatory programs.
Which brings us to one of the other more, if not unique aspects, but special aspects of this discussion, which is the role of government. And one of the things that has been instrumental in channeling the efforts in dialysis care is the prospective payment system, the so-called bundle, which has incentivized corporate efficiency, but has decoupled reimbursement from individualized patient care. How do you see that playing out in your experience?
What I would say is that, the ESRD prospective payment system really has evolved. As Dr. Lin mentioned, we first saw portions of bundling payment systems back in the 80s, and that has evolved. And that actually does incent efficiency, which again has allowed corporatization to really come in full force. But at this point, starting with the fully bundled prospective payment system that began in 2011, which only excluded physician payment from that system, fortunately, there was the addition of a quality incentive program, the QIP, the following year. However, can you really measure quality on behalf of patients? So a lot of people, both nephrologists, patients, and others in the kidney care community have wondered whether with this more fully bundled care system, are we truly providing at least a bare minimum of reasonable quality to our patients? And so I think the government, CMS, is watching very closely. How do you increase payment and then increase incentives for innovation when you have a bundle of money such that you can't attract, for example, private equity because you're not necessarily going to get reimbursed for the new technology, the new therapies that could be incentivized if there were payments outside of a bundled environment?
Yeah, I mean, I'd probably have too many thoughts on this, but maybe I'll focus here, which is that, again, if you go back into history, you can see how there has been this perpetual cat and mouse game where the federal regulator is looking for what we might call fraud, waste, and abuse by industry that's looking for, dollars to kind of support the enterprise. And if you go back and look in the 1980s, for example, there was a big increase in peritoneal dialysis because of an add-on payment to cyclers. So much so that if you look at what the GAO reports in the late 1980s, they're talking about cracking down on DME companies that are providing cyclers to patients who aren't good candidates for peritoneal dialysis. And what happens is in the 1990s, they crack down on that add-on payment, and you see a predictable decrease in the use of cyclers. And then with the advent of EPO, you then see like a big ramp up in the use of EPO, which then leads to MIPA and the government looking to crack down on the overuse of EPO through our modern bundle. And then even now today, you're starting to see in like the 2010s, right, this concern that we don't have enough home dialysis. And so then you see policies that are aimed at incentivizing more home dialysis. So I think sometimes it's very helpful to go back in history and sort of see how do we get to where we are. And the thing that I worry about is that, I think sometimes it's easy to have tunnel vision about what is the problem for today and what is the cat and mouse game going to look like for today. But there is this sort of vicious cycle where the policies get increasingly more complicated and the government needs to extract more and more accountability. It becomes a very overwhelming layer of regulatory policy that makes it difficult for providers, especially like small providers like individual nephrologists, to compete. And so, for example, the QIP has gotten very large, and so has dialysis facility compare. The number of measures in those programs is astronomical. And if you look at the average nephrologist or, like the average independent dialysis facility, I think they struggle to figure out how do you navigate that. And that's a product of many, many years of cat and mouse. That's not just like, a regulator one day kind of waking up and saying, this is what we're going to do. I think, the government is very well intentioned, but oftentimes we kind of take a step back and we wonder, how did we get here? And I do worry about what the current environment looks like. But, it is true that back when the bundle was implemented, there were big abuses of EPO. Like we needed to solve that problem. And so the question is, where do we go from here without layering on more policy on top of policy?
Yes, and at the same time, we can't just depend on KT over V, which a lot of people have criticized because of its failure to really measure quality. You were going to say something, Dr. Tanna?
Andrew, you and I are thinking exactly the same way. I was thinking of that exact example. What we have is the nephrology kidney care leaders, the nephrologists, are facing competing priorities from payers, and specifically CMS. We've got this cost control initiative that we know we need to do, and yet we have this quality initiative, this need to innovate, and oftentimes those two things are not meeting together. I've got three short examples. One which you just brought up, which is from a patient perspective and from a nephrologist perspective, we are measured on whether we're achieving a quality measure called KT over V specifically for our PD patients. And yet we don't really know that the KT over V that we've selected for these PD patients actually results in meaningful improvement in quality of life. And so there's been a lot of data about what is the right KT over V for a PD patient. Secondly, when we talk about the need for increasing our home penetration, and of course, this was highlighted by the president's initiative a few years ago during the first Trump run. The need to increase home penetration, we all know we've kind of reached a point where we're not growing as fast as we should be with respect to home penetration. We know staff assist would help the nephrologists boost home penetration higher, and yet from a cost perspective, we're running into difficulty there. And then the third example is just in this last innovation, the CKCC, we look back to the May announcement of 2025, where we know that nephrologists are now being rewarded and encouraged to push transplant for our stage 4 and 5 and ESRD patients, and yet for cost reasons, the transplant bonus was removed starting in January of 2026. So we have this persistent fight between the need to cost cut and the need to innovate.
I just wanted to point one thing out with respect to the evolution of federal policy, which is that I do think that historically the government has really concerned itself mostly with who's holding most of the capital, and that would be, the dialysis chain or the facility. And in many ways, the nephrologist, who is supposed to be the principal decision maker for the patient and really is the agent who is advocating on behalf of the patient, is cut out from a lot of that policy. And, I think rightfully, right, the government's worried about, the taxpayer. But 20 years later, I think you realize, wait a second, like, why have the corporate entities grown so powerful? And it's because a lot of that interest is, a lot of the attention has focused on that and not on the nephrologist. And what you can see is, well, why did the ESCO model, most of what it did was it increased outpatient dialysis treatments and reduced the number of hospital inpatient stays, but it didn't really do a whole lot with respect to how do we plan for dialysis? How do we help patients transition in a more patient-centered way? How do we get more home dialysis? How do we do more transplant? And if you look at the evolution of how federal policies have gone, in the most recent iteration, you see that in the KCC model, the nephrologist is supposed to be at the center of the model. And in the KCF in particular, it's a nephrologist-centric model. And if you look at the evaluation from those policies, you see exactly what you'd expect, which is that you see more optimal starts. You see a lot more planning for the dialysis patient. You see a lot more home training. You see a lot more preemptive transplant waitlisting. These are all things that you would not expect for a corporate entity to care about, or even if they did care about, to be able to do. The nephrologist is the entity that is able to do that. And if you zoom out and you look at how ACOs operate in general, you see that hospital-based ACOs do not save a lot of money. That where you see most of the success is physician-led ACOs. And it really kind of points to this question about, yes, I think 20 years ago, the elephant in the room is sort of thinking about what is the corporate entity doing with money and how do you shield the taxpayer from that? But if we really want to care about what do patient outcomes look like and how do we facilitate better patient outcomes, the government, I think should look at the body of evidence and recognize that physician leaders are the ones that are going to facilitate that change. And we should be really worried, I think, about, not just nephrology, but you see, corporate entities gobbling up private practices through all of medicine. And I'm really worried that, the lessons from nephrology are not being translated into medicine, broadly speaking. And what we really need is a lot more physician leadership.
Yeah,
I think that that's an incredibly important point. And I just want to add one more comment, just talking about these physician-led initiatives versus corporate-led initiatives. So if you look at the CKCC model and you see with some of the nephrology-led issues that you're talking about, with increased transplants and increased, reasonable starts in terms of staying out of the hospital, tremendous amount, but Medicare ended up paying $300 million for that, and so they are not comfortable paying that much for that type of quality. On the converse, you can see at the same time the mandatory value-based care model, the ESRD treatment choices model, which did not succeed. You saw no increase in home dialysis and no increase in transplant to the outcomes that the government was looking for. You have to wonder if, because those were led by the dialysis organizations, it wasn't that physicians decided to put the skin in the game. Rather, it was a mandatory randomized trial, essentially. That's why you didn't see the comparative improvement and increase. So again, I think that is a vote in favor for the nephrology-led practice to actually do better for their patients.
This is a perfect transition to another issue that we've been talking now about, the downstream effects of corporatization and government involvement. One of the other things that you are implying is the impact on nephrologists themselves. And I don't think it's an exaggeration to say that our specialty has been in crisis for a while. We've had trouble recruiting. We have not been filling fellowship programs. We're facing, if you will, a professional crisis and a crisis of professionalism. And there's been kind of a de-emphasis of nephrologists as clinical leaders, which you were all pointing out is really necessary, to being kind of a corporate officer with, the medical director with limited autonomy and decision-making opportunities. This also puts the nephrologist, particularly the medical director and others, in these conflicts of interest with the corporate entity. What has been your own impression about this, and how it has been impacting our specialty?
I mean, this is a big hobby horse for me, and those people who talk to me kind of know that I've been increasingly talking about this. I do want to point to one piece of evidence that I think it may be too much to generalize, but I'm going to generalize anyway, which is, we wrote a paper looking at financial conflicts of interest between nephrologists and dialysis facilities, specifically looking at nephrologists that have an ownership interest in a dialysis facility. And, like every good health economist, we hypothesize that those conflicts of interest might negatively impact patients. But what we find is the reverse. What we find is that JV owners of dialysis facilities are more likely to push home dialysis. And you take a step back and you think about it, it's like, wait a second. The MBAs in the C-suite, they don't need an MD in the room to squeeze out more profits. Like me being in there, like they don't need, Dr. Tanna's or Dr. Watnick to help them, gerrymander their Excel spreadsheets a little bit more. What they need the physician in the room to do, if they're in the C-suite, is to be, professional, to be a leader, to push patient care. And I think that is the lesson there for me, is that as a specialty, we have forgotten how to flex the muscles of leadership. And everybody knows working out is really hard. And having, I tell my children, if you don't exercise your reading muscles, it'll be easier for you to watch TV. But the reality is that leadership is difficult, but it's super rewarding. I think that if we advertise to trainees that our specialty is one in which we just sit back, we're not leading, we allow the corporate entity to take over what we're doing, and we kind of focus all of our care on dialysis, I'm not sure that's a huge sell for our trainees. What we need to demonstrate and model is that we are leaders. We are entrepreneurs. We're going to push the entirety of the spectrum of kidney disease. We're from pre-dialysis care, the transition to dialysis, home dialysis, uptake of new technologies, thinking about GN, thinking about onconephrology, et cetera, et cetera. How do we as a specialty become leaders and push the envelope on generating value for society? I think that is what we need to advertise for trainees. And I think trainees are itching for working hard, and they're looking for purpose. They're not going into medicine just for to be a corporate, I don't know, cog in a machine. They want to be leaders. And so we need to show, how do we be leaders? That's what I think. And I do think that, policymakers should pay attention to that. And I think they should take lessons from, the successes that they've gotten in nephrology-centric policies. But ultimately, as a specialty, I think that's what we need. We need to seize that mantle of leadership.
I think you should be either delivering or at least writing the next ASN presidential address. That was very inspirational. So I think this is great, because this is really where we're headed now, is what are we going to do about this? What are the future possibilities in this shifting landscape for dealing with the corporatization issue? What are our options here, in addition to what Dr. Lin said in a very inspiring few moments?
I was inspired, and I am inspired by Dr. Lin, and I will take the ball for just a little bit to add some comments. And, I think that throwing dollars at this issue, certainly that can help. But we've seen that throwing dollars is not necessarily the solution. Certainly with the ESRD treatment choices, trying to get the best treatments to patients, such as getting them on a wait list or getting an increase in living donation or increasing home, is not necessarily where the dollars are going to make a difference. The place that we're going to make a difference is basically flexing those muscles, those leadership muscles, and making sure that there's a physician in the room to recognize the importance of the care for the patient. And when you're talking about the influence on the system, I think you need to look at those legislative and regulatory levers that we can press above and beyond the dollars that we can throw. So how can we think about increasing appropriations, for example, for innovation, for research innovation? We have the Transforming Kidney Health Research Initiative and report that was just put out. Samir Parikh, our current ASN president, chaired that committee, but it included people from AKP and National Kidney Foundation and the American Kidney Fund, really the kidney community, to really speak out about needing a new perspective to make sure that we're looking for innovation. So how can we go to the appropriators and expand dollars for innovation, for example, through KidneyX, which has been a vehicle that continues to be supported throughout administrations across the aisle in both chambers of Congress? Believe it or not, kidney care is a place where people have come together across the aisle. How can we get the optimal therapies to our patients? This Congress has not been very productive. In fact, we've been told it's been the least productive Congress in recent past. And yet, for example, we just had the HOLD Act, the Honor Our Living Donors Act, passed at the end of January, so we can make it easier to give the gift of life and living donation. Having an Officer of Kidney Health and Transplantation, which is an initiative from ASN and the kidney community, to have somebody sitting in the immediate office of the secretary, waking up every morning and thinking about kidney care and coordinating within the agencies. So these are ways that we as nephrology leaders can help activate others and make sure that we're putting into effect the legislative and regulatory levers that can make it more exciting to go into nephrology and can make it such that we see a future for the care that we're providing in innovative ways to benefit our patients who need our help.
Suzanne, you also raised the possibility of seeing the dialysis unit as not simply a place of providing kind of routinized care, but also as a research laboratory for trying some of these new innovative techniques. I wonder whether you, Dr. Tanna, have any thoughts about how that would work out in your experience.
Well, I think Suzanne said it very well. We have a problem in terms of reimbursement for innovation. We have a time-limited innovation strategy unfortunately, in our dialysis population right now. So things that we would like to try, we have a period of time where we can try them, and then we're not sure they're going to be reimbursed going forward. We really, and I think it was very well stated by Gene and Suzanne, we really need to engage our stakeholders at CMS and among our payers to incentivize innovation. As Suzanne brought up earlier, we've got exciting dialysis technology coming to the United States, but that is expensive dialysis technology. And while it'll improve mortality, it's going to be difficult for dialysis clinics, especially those that are not part of a large entity, to be able to provide those types of technologies to patients. So, and just to piggyback on your question earlier about the need to address our workforce shortage, I do think that trainees, they see nephrology as one of the most intellectually stimulating subjects among all of the subspecialties. But for whatever reason, whether it's the shortage, our lifestyle, the need to take on a lot of transportation as we're working, we're not seeing the interest in our subspecialty that we should. We really do need to emphasize how we are innovating with respect to rare diseases, and hopefully as we innovate with respect to our dialysis population and transplant going forward.
Yeah, I mean, I think that the entire portfolio of innovation, like as a specialty, we really need to think about very carefully. I would say that I do think that we're at a crossroads, and a fragile one, to mix metaphors, I guess, but one that I think is a little bit, precipitous, I guess. I do worry, because if you look at where, like, the entire spectrum of innovation across kidney disease, there's a lot of new technologies that are coming out, not just in dialysis, but I think, to Dr. Tanna's point, in dialysis as well. And I think that as a specialty, if we are fixated on simply dialysis-centric innovation, the rest of the innovative world is going to pass us by as a specialty. And I do worry, for example, that as cardiologists, for example, are seizing the mantle with CKM, which, I've been telling a lot of my colleagues, I cannot believe that it's called CKM. It should be called KCM or KMC. And that is that kind of speaks to a type of, frontier of innovation that if we do not seize, it will pass us by. And I think it's just very important that we push into that. I was very heartened, actually, by our latest Kidney Week and Dr. Parikh's remarks in the President's address, but just in general, ASN has been recognizing this and pushing a lot more aggressively in trying to have more innovation in areas that are not just dialysis-based innovation. And I do think that is the future of nephrology. It's something that we all should be thinking about.
I have to add that, for any clinician scientist, the modern dialysis unit should really be an ideal research environment. I mean, if you think about it, this is a place where it is controlled, you can go in, and yet it's been a challenge for researchers to access this. Dialysis organizations understandably have issues with regards to working shortages and making sure that things are smooth and infection prevention and control. And yet we do have examples in the country of dialysis organizations that do foster a culture of research. So, for example, with DCI, Dialysis Clinic Incorporated, or Northwest Kidney Centers, we partner with the Kidney Research Institute, and it's a culture of research where the patients are not surprised when they see people approaching them with research protocols. I know I'm bringing it back to the dialysis environment, but talking about levers to think about, if you're going to talk about incentives, perhaps the government recognizes that it's an expense to provide research and innovation in a dialysis facility. Is there a way that if you're doing that as a dialysis facility and participating, that there can be some type of reward? And I don't know what that might be, but if there's an incentive program and points to be given, maybe this is an area you can think about in a way that even in a bundled environment to incent innovation.
The only thing I would add to that is this is going to get more challenging as we talk about dialysis patients expecting to increase their numbers into Medicare Advantage. And so we're going to have less information shared with CMS as those types of patients increase in number. And so we're going to have to think of solutions to using the dialysis unit as a place of study.
Well, this has been a fascinating and enlightening conversation, at least for me, and I'm sure for our audience. I want to thank all of you for your participation today. This has been really a great experience.
This podcast is copyrighted by the American Society of Nephrology. All rights reserved. All content in this podcast is for informational purposes only and is not intended to be medical advice. This podcast should not be used in a medical emergency or for the diagnosis or treatment of any medical condition. Please consult your doctor or another qualified healthcare professional. If you have any questions about any medical conditions or before taking any drug, changing your diet, or commencing or discontinuing any course of treatment. Thank you for listening to this podcast by the American Society of Nephrology.